Abnormal uterine bleeding and infertility and a few of those other topics are there still left for me. I'll just do it as fast as possible and I'll go to sleep. Dysfunctional uterine bleeding is named as a state of abnormal uterine bleeding without any clinically detectable or organic pelvic pathology. So you'll be having, there are two types. You have anovulatory and ovulatory. Anovulatory, you'll have puberty, menorrhagia, metropathia, hemorrhagica or cystic glandular hyperplasia, premenopausal DAB. In ovulatory, you'll have irregular ripening of corpus luteum. You have irregular striding of corpus luteum or Halban's disease. IUCD insertion will be there, and following a sterilization operation. Then management protocol for DUB is pre-puberty adolescent less than 20 years, menorrhagia, reproductive period within which is 20 to 40 years, postmenopausal and premenopausal. Okay, so during reproductive period, if cycles are regular, then medical management for 3 cycle. If it is responsive, then you have to do follow-up. If it's unresponsive, then you have to assume cycle is irregular and excessive, and ultrasonography, hysteroscopy, endometrial sampling, DNC and laparoscopy should be done. If pathology is detected, then you have to treat accordingly. If there is negative finding, then family is completed, and then you can provide a LNG IUCD, endometrial ablation and resection, hysterectomy can be done. If family is not completed, then medical management, LNG IUCD and follow-up can be done. Then okay, premenopausal, you have cervical cytology you have to do. Ultrasonography, endometrial thickness, sonohysterography, endometrial pathology, hysteroscopy, endometrial biopsy, sampling, DNC and laparoscopy should be done. Sonography, hysteroscopy, endometrial sampling, DNC, laparoscopy. Okay, if malignancy is excluded, you do endometrial if it is proliferative, and if it is hyperplastic, then you can provide prostaglandins, which may be responsive with requiring endometrial sampling, and if it's unresponsive, then endometrial ablation, resection or hysterectomy can be attempted. And then if endometrium adenomatous hyperpolyposis, atypical hyperplasia is here, then hysterectomy has to be done. Okay, so management protocol of puberty, menorrhagia, rest assurance and hemanthics. Heavy bleeding will continue and you have to admit for investigation. Then hemoglobin percentage, you have to check peripheral blood count, platelet count, clotting factor study, ultrasonography, thyroid profile and blood transfusion if required. All of them has to be done. So primary and secondary to this dysfunctional uterine bleeding. Progesterone therapy you have to provide methoxyprogesterone acetate. If it is responsive, you have to complete 2 to 3 cycle. If it's unresponsive, you have to give conjugate estrogen, which may be responsive or unresponsive. If it's responsive, then you have to replace therapy with combined OC pills and containing 50 micrograms of estrogen. If it's unresponsive, then you have to do EUA and DNC and biopsy. Secondary to this thing, you have thyroid dysfunction, idiopathic thrombocytic purpura, leukemia, non-ovarian polyposis, and anatomical disorders and pregnancy complication. You have to provide appropriate therapy. So, uterus conserving surgeries for DUB is endometrial ablation or resection. Various surgeries are transcervical resection of endometrium, TCRE, and roller ball endometrial ablation, and NDYAG endometrial ablation. Indicated in failed medical treatment, women with who want to preserve uterus and fallopian uterine fibroids, which is less than 3 centimeters. Contraindicated in pregnancy, acute pelvic infection and endometrial hyperplasia. Pregnancy, acute pelvic infection, endometrial hyperplasia, the endometrial ablation or resection is contraindicated. Transcervical resection of endometrial, endometrial ablation, and NDYAG endometrial ablation. Indicated failed medical treatment. So first, in this treatment, you have to, after if it continues, admit investigations you do. Hemoglobin, peripheral clotting, ultrasound, thyroid and blood transfusion you do. Then if it's primary DAB, which is majority, you provide medroxyprogesterone acetate. 10 to 20 gram. If it's responsive, then you continue for 2 to 3 cycle. If it's unresponsive, then you give conjugated estrogen. If it's responsive, then you replace the therapy with combined OC pills, and if it's unresponsive, you do EUA and DNC and biopsy. Then if it is secondary causes, then you have to do thyroid dysfunction, ITP, leukemia, 1 million bad disease, anatomical disorders, and pregnancy complications. Then you have metal schmerz or ovular pain. This is a sharp pain in the lower abdomen every 2 weeks before menstruation, suggesting metal schmerz. Pain is associated with rupture of ovarian follicle at the time of ovulation, peritoneal irritation by the follicular fluid. Okay, appears in mid-menstrual period, hypogastrium pain, nausea and vomiting will be absent, lasts for less than 12 hours and associated with slight vaginal bleeding or mucosal drainage. So you have to assure and provide analgesics, and refractory cases cycles are maintained by giving OC pills. Metropathia or metropathia hemorrhagica or cystic glandular hyperplasia or what is this? Schrodinger's disease. It is mostly seen in premenopausal women. Maximum age is 40 to 45 years. It is a specialized form of TUB. So basic fault will lies in the ovary. There is a slow increase in secretion of estrogen, but no negative feedback loop inhibition of FSH. There is gradual prolonged rise of estrogen leading to initial amenorrhea and later ovulation. There is no progesterone support to support the endometrial, and eventually entire proliferated endometrial becomes weak and is shed. Heavy bleeding which continues for a long time. Okay, this is metropathia hemorrhagica, which is cystic glandular hyperplasia or Schrodinger's disease. It's in the ovaries. Slow increase in secretion, but no negative feedback inhibition will be there. It's a clinical feature: prolonged amenorrhea 6 to 8 weeks, and followed by excessive painless bleeding and ovulatory bleeding. Endometrial hyperplasia, cystic glandular hypertrophy lined by columnar epithelium and follicle containing estrogen. So MPA is 10 mg from TID from 5th to 25th day of the cycle. Abnormal AUB, which is any uterine bleeding outside normal value, duration, regularity or frequency is considered AUB. So normal menstruation, you have cyclical interval 28 days, which is 21 to 35 days. Menstrual flow will be for 4 to 5 days. Then menstrual blood loss is around 35 ml or 20 to 80 ml. So classification of abnormal uterine bleeding, you have palm, coin. So structural causes: polyp, adenomyosis, leiomyoma and malignancy. And coin, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic and not yet identified. Iatrogenic is doctor in English. Coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not yet identified. Leiomyoma, malignancy, polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, endometrial dysfunction, endometrial, iatrogenic, not yet classified. So clinically the types here physiological and pathological. Physiological is before puberty and during pregnancy, lactation, following menopause. It will be during physiological. Pathological is concealed, which is cryptomenorrhagia, which is acquired, and congenital or acquired, and you'll have two, which is primary and secondary. Those are the classification: pathological, concealed, cryptomenorrhea, congenital or acquired, real to primary, secondary. Okay, physiological is primary before pregnancy, secondary during pregnancy. Pathological amenorrhea is before pregnancy is pituitary gonadotropins not adequate to stimulate ovarian follicles for effective steroidogenesis. Estrogen levels not sufficient to cause bleeding from endometrium. This is physiological amenorrhea. Before puberty, the gonadotropins not adequate to stimulate ovarian follicles for effective steroidogenesis. Estrogen levels will not be sufficient. During pregnancy, there is increased estrogen and gonadotropin release from trophoblast, which suppresses the pituitary gonadotropin, and no maturation of ovarian follicles will occur. During lactation, high level of prolactin inhibits ovarian response to FSH, no follicular growth, hyperestrogenic state, no menstruation. Okay. No maturation of ovarian follicles also basically. Okay. Following menopause, no response to follicles are available in ovaries for gonadotropins to act. Okay. Menopause, there is no follicles only, so gonadotropins will not act only. Cessation of estrogen production from ovaries with elevation of pituitary gonadotropins. Then primary and secondary amenorrhea. Cryptomenorrhea is occurrence of menstrual symptoms without external bleeding. Menstrual bleed fails to come out from the genital tract due to obstruction in the outflow tract, caused by congenital or it may be acquired. Congenital, imperforate hymen and transverse vaginal septum causes and acquired, you will have cervical stenosis following amputation, cauterization and conization. Primary amenorrhea with normal secondary sexual characters, cyclical abdominal pain will be there, and hematocorpus will be there. Local examination, you will have a bluish hymen. Parectal examination to assess the size of the uterus. PV is never done in a virgin female. Then management is cruciate incision in the hymen. Blood drains automatically. The primary amenorrhea, absence of menses at age 14 without secondary sexual development, or absence of menses at age 16 with secondary sexual development. Etiologically, there is disorders of outflow tract and uterus. Malarian age anomalies will be there. Androgen insensitivity syndrome will be there. Testicular feminizing syndrome. Disorders of ovary, you have gonadal dysgenesis, Turner syndrome, which is 45XO, pure gonadal dysgenesis, which is 46XX, Swyer syndrome, which is 46XY, and Savage syndrome, which is resistant ovary syndrome. Then disorders of anterior pituitary, you have neoplasia, prolactinomas, craniopharyngiomas, hypopituitary state, Siemens disease, Chiari-Foumel syndrome, and Forbes-Alberts syndrome. You have disorders of CNS, which is Kalman syndrome, which is amenorrhea with anosmia and adrenal hypoplasia. This is primary. So disorders of outflow tract or uterus, Malarian anomalies, androgen insensitivity syndrome, testicular feminization syndrome, gonadal dysgenesis, Turner syndrome, pure gonadal dysgenesis, Savage syndrome. Savage syndrome is resistant ovarian syndrome. Then you have neoplasia prolactinomas, cryptopharyngiomas, pituitary states, which is Siemens disease, Chiari-Foumel syndrome, and Fowles-Blight syndrome, Kalman syndrome, adrenal hypoplasia. So investigations of primary amenorrhea, you'll have either normal sexual secondary characters or poor or absent sexual secondary characters. This entire flow chart you have to remember, though. Primary and secondary amenorrhea is this one important topic. Okay, fine. Pelvic ultrasonography and laparoscopy you have to do first of all. Okay, then if uterus is absent, then karyotyping you have to do, miliary agenesis and adrenal insensitivity syndrome you have to test for. Okay. Then androgen insensitivity or miliary agenesis. Uterus is present, then you do outflow tract obstruction or anomalies if it is there. Yes, you don't have to actually remember a lot of these things. Only resistant ovarian syndrome you have to remember. Gonadal dysgenesis, Turner's pure gonadal dysgenesis, or Sawyer syndrome. None of those you have to remember. Turner syndrome, gonadal dysgenesis, Malarian anomalies, androgen insensitivity syndrome, which is testicular feminizing listening, anterior pituitary neoplasia prolactinomas, craniopharyngiomas, hypopituitary state, Chiari-Foumel. CNS, you have Kalman syndrome. Okay. So normal secondary sexual characters are present. Pelvic ultrasonography or laparoscopy you can do. Uterus will be absent, you can do karyotyping. If uterus is present, you can do outflow obstruction or anastomosis. Then normal anatomy if it's there, or FSH, LH, TSH, prolactin estimation you have to do. So if it's low or normal, then you do physiological delay is there and hypothalamic. If it's elevated LH or FSH, you do PCOS. If it's FSH or LH is increased, you do premature ovarian failure, resistant ovary and gonadal dysgenesis. If it is TSH is abnormal, then you do hypo or hyperthyroidism. Then if prolactin is increased, hyperprolactinemia, you have to do MRI or CT scan. Then poor or absent secondary characters, you check the health, height, if it is normal or if it is short. If it is normal, you can do FSH or LH. Low or it will be normal. Physiological delay, Kalman syndrome will be there, and cranial CT MRI to exclude CNS lesions can be done. If it is high, you can do karyotyping, and if it is normal female, primary ovarian failure, resistant ovary or gonadal agenesis. If it is normal male, then gonadal agenesis. So we do height. If it is normal, then FSH and LH. If it's low or normal, then it's physiological delay. Okay. CNS lesions you have to exclude. If it is height is short and if FSH is low, then it is what do you say? Hypothalamo-pituitary dysfunction and intracranial lesion, cranopharyngioma may be there. So if it is FSH and LH is height, you have to do karyotyping for gonadal dysgenesis. Actually, I think this flowchart is not proper, not correct. Refer TV. There was another flowchart which was more proper, I feel. But yeah, FSH LH, it may be if it's low or normal, if it may be physiological delay or hypothalamic. Elevated FSH LH by FH. If LH by FSH is elevated, then it's PCOS. If FSH is increased and LH is increased, primary ovarian failure, resistant ovary or gonadal dysgenesis. If TSH is abnormal, then hypothyroidism or hyperthyroidism. If prolactin is increased, then MRI, hyperprolactinemia you have to assume, and you have to do MRI and all. Okay. Then we have secondary amenorrhea, which is absence of menstruation for more than 6 months in a woman who had established normal menstruation before. So etiologically, you have disorders of outflow tract or uterus. So cervical canal, severe stenosis or atresia following electrocoagulation, chemical burns, cervical amputation, conization, carcinoma in situ, genital tuberculosis, and it may also be VVF. In which the cause is unknown, and Osterman syndrome also it may be there. Then you have disorders of ovarian tumor, you have vascularizing tumor or PCOD, trauma, you have surgical extirpation or radiotherapy, infections like mumps, tuberculosis are seen, and premature ovarian failure may be seen. Disorders of anterior pituitary, you have hyperprolactinemia, empty sella syndrome, Sehan syndrome, Simon's disease. Then disorders of hypothalamus, you have GnRH deficiency, you have radiation, pseudocystis, infiltrative disease like sarcoidosis, and craniopharyngioma. Then if you have other causes like pregnancy, hypothyroidism, diabetes, Addison's disease, Cushing syndrome, and drugs like reserpine, OCP, antidepressants. All of these lead to secondary amenorrhea. So severe chemical cervical canal stenosis, VVF, Asherman syndrome, disorders of the ovary, ovarian tumor, muscularizing tumor, PCOD, trauma, surgical expiration, and radiotherapy, infections, trauma, premature. Disorders of anterior pituitary, hyperprolactinemia, empty sella syndrome, Sehan syndrome. Hypothalamus disorders, you have GnRH deficiency, radiation, pseudocystis, and infiltrative disease. Management is investigation of secondary amenorrhea. You have to exclude the pregnancy, you have to estimate serum TSH and prolactin, and X-ray, CT, MRI you find for sella turcica. Sehan syndrome is most recent. TSH will be increased, prolactin will be increased, and there is subnormal sella. If investigations are normal, then you do progesterone challenge test. If withdrawal bleeding is present, then HPO axis is intact. Then adequate exogenous E2 serum estradiol has to be assumed. You have to check. Okay. Then FSH LH you have to assume, check. And if FSH LH is more than 3 and LH is more than 10, you have to do pelvic ultrasonography, and you can assume polycystic ovarian disease. So progesterone challenge test. If everything is increased, then okay, look, secondary menorrhea. If TSH TRL, 1 second. Okay, we're almost done. Leave it. Okay, if TSH, prolactin and abnormal cilia is present, then hypothyroidism or pituitary adenoma can be there. If it is normal, then progesterone challenge just if withdrawal bleeding will be present or it will be absent. If it is absent, there is loss of progesterone receptor and decreased endometrium. So estrogen progesterone challenge test you can do. If bleeding occurs, then endometrial is responsive and estrogen estradiol is being production is low, less than 30 picogram per ml. If there is no bleeding, then it is a non-functioning endometrium and uterine synechiae is present. USG and or hysteroscopy should be done to rule out synechiae. So in estrogen progesterone challenge test, if bleeding occurs, then you have to estimate FSH and LH. If it is high, then it's ovarian failure or resistant ovarian syndrome. Age less than 30 years, you have to do karyotyping. Okay. If it is low and LH is less than 5, then it may be a hypothalamic or pituitary lesion or dysfunction. GnRH dynamic testing can be done. If it is positive, it is hypothalamic, and if it is negative, then it is pituitary. You can do GnRH testing. Okay. Sheehan syndrome is systemic necrosis of 75% of anterior pituitary due to spasm of arteries because of hemorrhage or shock. Ischemic necrosis 95% due to spasm of arteries because of hemorrhage or shock. It can be 75 or 95%. Clinical features, you'll have symptoms. There is failure of lactation. There is failure of lactation after delivery, which is decreased prolactin. You have secondary amenorrhea, which is decreased LH and FSH. There is loss of libido. There is increased sensitivity to cold due to decreased TSH, leading to hypothyroidism. There is absence of axillary swelling, loss of axilla and pubic hair will be there. There is decrease in skin pigmentation. There is anemia due to lack of pituitary erythropoietic factor. There is weakness and lethargy, hypothyroidism, hypothermia, hypoglycemia due to decreased insulin resistance, and all genital organ shows atrophy. So investigations, you can do hypoprolactinemia and decreased LH, FSH, TSH, ACTH and estrogens. Hyperprolactinemia, LH, FSH, TSH, ACTH, estrogen will be decreased. Management, you have to provide lifelong HRT for estrogen, progesterone, thyroid, adrenal hormone. Then fibroid uterus, fibroid leiomyoma or myoma or fibromyoma is a smooth muscle tumor of uterus. Site location, it may be body or it can be cervical. Cervical in the body, in the corporal, it will be interstitial, subserosal or submucosal. Interstitial is intramural. Subserosal may be just below the serous, or it may be broad ligament, or it may be watering parasitic. In submucous, it may be sessile or it may be pedunculated, which is polyp. Cervical polyp will be anterior, posterior, central or lateral. Okay. So staging of polyp, I have to read. Staging FIGO of polyp. I have to Risk factors, it may be due to nulliparity, it may be due to obesity, hyperestrogenic state, and black women. All of these are risk factors for fibroid uterus. Black women, hyperestrogenic state, obesity, and nulliparity. Then symptoms may be asymptomatic. They may have menstrual abnormality, which is menorrhagia and metrorrhagia. They may have dysmenorrhea, dyspareunia. Infertility will be there. Distortion of uterus, difficult sperm ascent, and defective implantation. Infertility is one of the more common symptom complaints that people come with. And then menorrhagia, metrorrhagia, recurrent pregnancy loss, miscarriage, preterm, lower abdominal pain or pelvic pain, abdomen enlargement, pressure symptoms, broad ligament fibroid, uteric pressure, ureteronephrosis, pileitis, bladder you will find urinary retention, GI tract you will find dyspepsia and constipation, venous and lymphatics you will find edema and varicosity, sacral plexus pain in the pelvic region. Okay, then complications, degeneration, it may lead to atrophy, it may lead to red degeneration, which is cavernous degeneration seen in second trimester pregnancy. Okay, then it may be hot hyaline degeneration, avoid red hot fatty meat chicken. That's the thing. Atrophy may be there, red degeneration, hyaline degeneration, fatty degeneration or calcification, mixed edematous degeneration, and cystic degeneration. Okay, all of them can occur. Necrosis can seen, calcification will lead to womb stone, infections can seen, vascular changes will be there, sarcomatous changes will be there, torsion of the subserous pedunculated fibroid will be there, hemorrhage may be seen, polycythemia will be there because erythropoietic function by the tumor. The tumor has a erythropoietin releasing function. Okay, it alters erythropoietic function of kidneys through ureteric pressure. Okay, it may be appendicitis, twisted ovarian cyst, pileitis, adenomyosis, and ovarian tumor, and full bladder. Investigations, you can do ultrasound and color Doppler, TVS, transvaginal scanning. So uterine contour is enlarged and distorted, and vascularization is more at periphery of fibroid, less at center of fibroid, and central vascularization indicates degenerative changes. Then you have saline infusion sonography, SIS. You have MRI, you have laparoscopy, and you have hysteroscopy. Saline infusion sonography, MRI, laparoscopy, hysteroscopy. Then management of fibroid, you have asymptomatic, which is supervision, and surgery, asymptomatic, which is medical treatment, which is temporary treatment, and surgical measures, which is myomectomy, embolotherapy, and abdominal hysterectomy. Okay, so management, if indication of medical management, if only to treat the anemia and recover hemoglobin levels before the surgery. So in order to decrease the blood loss or menorrhagia, long-acting IUCD and oral contraceptive pills, tranexamic acid can be provided. Tranexamic acid. Then to reduce size of large fibroid, you can give eliprostone, aromatase, letrozole, GnRH agonist, antagonist, mifepristone, danazole can be provided. If woman is approaching menopause and wants to avoid surgery, then also you can do that. And women with contraindication to surgery also, you can provide medical treatment. So indications for surgery in asymptomatic patient: fibroid larger than 12 to 14 weeks of pregnancy, rapidly growing, subserous and pedunculated fibroid which is prone to torsion, likely to complicate a future pregnancy, and unexplained fertility and unexplained recurrent abortion. Wait 1 second. There is sarcomatous changes also there. That is one important thing which can be there as an indication. Specific indications for hysterectomy: patients more than 40 years, multiparous, fibroid associated with malignancy, and uncontrolled hemorrhage during myomectomy. All of them require to be hysterectomy. Embolization also can be done. Embolotherapy and abdominal hysterectomy is treatment. Okay. You have endometrial adenosis and endometriosis. This will take some time. All these drugs is really important, man. They'll ask individual drugs only. Ovarian hyperstimulation syndrome and infertility and sterility. This is one of the more important topics. You just have to remember it. This I'll finish it off. Female infertility causes also, yes. Then cervical factors of infertility, tubal factors of infertility, yes. Controlled ovarian hyperstimulation, dyspareunia, assisted reproductive technology, IVF and all, fern test during mid-cycle and stuff like that, birth control and medical termination. Medical termination is important. So this it's okay, you can do this very very fast. Sterilization also okay, you can do it somewhat quick. Synchroman is the only thing they'll ask. MTP also not that important, but after that prolapse I already did off on my own, so I'm not going to do. Then benign ovarian disease from here onwards, page number 76 onwards is very important. This you have to do all of these. Bartholin's absence, vaginosis, pelvic inflammatory diseases, genital TB, Asherman syndrome, uterine syndicate, candidiasis, pelvic abscess, gonorrhea. All of them are very important, and maybe cancer I'll do tomorrow before the exam. So it'll take around, technically it should take around 5 hours to finish all of these, but honestly I'm going to skip like so many of these. I'll do this very very fast, so I'm hoping I'll finish it off fast. Why is fibroid so big is the question I'm asking. Okay, daycare surgery is a selected surgical procedure where they are admitted and discharged on same day. Increase patient turnover, reduce hospital stay, reduce inpatient workload, reduce concomitant cost and disturbance of patient's daily work. Before discharge, before follow-up procedure, analgesia and avoidance of availability of emergency services are explained to the patient. Common gynecological surgery causes you have dilatation, curettage, termination of D&D, biopsy procedure, abdominal examination under anesthesia, endoscopic procedure like diagnostic hysteroscopy, laparoscopic sterilization, ovarian drilling and diathermy, and cervical resection and ablation of endometrium. You have degeneration of fibroid, which is carinous degeneration, seen mostly during pregnancy, especially in the second trimester, can occur in non-pregnant female women also. It is an aseptic condition. Myoma becomes acutely painful, enlarged and tender. Patient presents as acute abdominal pain, vomiting, malaise and slight fever will be there. Laboratory investigations will have moderate leukocytosis and rapid ESR will be there. Management is red degeneration should be managed conservatively, bed rest, analgesics to reduce the pain. There is no need for surgical intervention. Abdominal pain, vomiting, malaise, slight fever, leukocytosis, all of them can occur. Then sarcomatous change in fibroid into leiomyosarcoma can occur. Characteristically, there is recurrence of fibroid polyp. There is sudden enlargement of the fibroid. There is fibroid along with postmenstrual bleeding. Mechanism is increased surface area of the endometrium. Interference with normal uterine contractility may be there. Congestion and dilatation of endometrial venous plexus. Endometrial hypoplasia due to hyperestrogenism and which is an ovulation, and relative deficiency of thromboxane A2 are all involved mechanism of menorrhagia in fibroid uterus. Increased surface, abnormal uterine contractility, congestion, endometrial hypoplasia due to hyperestrogenism, anovulation, and relative deficiency of thromboxane A2. Okay, hysterectomy is the surgical removal of the uterus, cervix, ovaries, fallopian tube, and other surrounding structures. Abnormal uterine bleeding, malignancy, pre-malignant cases, uterine leiomyoma, endometriosis, prolapse of pelvic organ, chronic pelvic pain, and pelvic infections are all indications of hysterectomy. There is few types. You have subtotal or supracervical hysterectomy. Corpus of uterus is removed and cervix is preserved. You may have total hysterectomy or simple hysterectomy, wherein both corpus and uterus of the corpus and cervix of uterus is removed, and you have radical hysterectomy, which is removal of uterus, cervix, cardinal ligaments, and uterosacral ligaments. Methodology, you may be having vaginal hysterectomy, abdominal hysterectomy through an incision in the abdominal wall, laparoscopic hysterectomy, and robot assisted hysterectomy. Then procedure, general preparation, you have DVT prophylaxis should be provided. Patient positioning should be dorsal lithotomy position, and antibiotic prophylaxis. IV cephalosporin should be provided before the skin incision. DVT prophylaxis and patient positioning should be dorsal lithotomy position. So first you do laparotomy, uterine elevation, then round ligament access. You have to access the retroperitoneal space. You have to do bladder reflection, expose the internal iliac artery, iliac artery, divide the uterine vessels and skeletonize the uterine artery, divide the uterine vessels, dissect the rectum, divide the broad ligament, divide the vagina, close the vaginal cuff, and you have to do final examination and closure. Then complications, you have intraoperative complication, which is venous thromboembolism, genitourinary and gastrointestinal tract injuries, bleeding, nerve injuries, vaginal cuff dehiscence, and bleeding. So adverse drug reaction also may be there to the anesthetics, which is and your common sites of injury, you have infundibulopelvic pelvic ligament at the side of cervix, vaginal angle, and during pelvic peritonization. Post-operative, you will find ileitis, bowel obstruction, vaginal cuff dehiscence, infections will be there where vaginal cuff cellulitis and pelvic abscess can be seen. Fistulas will be there, which is vesicovaginal, ureterovaginal or rectovaginal fistulas can be seen. Prolapse of pelvic structures like fallopian tube will be seen. Post-operative ileus, bowel obstruction, vaginal cuff dehiscence, cellulitis, pelvic abscess, all of them can occur. Okay, intraoperative, postoperative. Venous thromboembolism, genitourinary, gestational tract injuries, bleeding, nerve injury, vaginal cuff dehiscence. Then you have myomectomy. It is enucleation of myotoma from uterus, preserving potentially functioning uterus capable of future reproduction. Prerequisites, you have anemia should be corrected. Anemia. Other causes of infertility should be excluded. Male factor infertility should be ruled out. Diagnostic DNC hysteroscopy should be performed to rule out polyp or endometrial cancer. Hysteroscopy or hysterosalpingoscopy has to be done to rule out fibroid, polyp or tubal block. Time of myomectomy, it is performed in immediate postmenstrual period to reduce the blood loss during surgery. It not performed during pregnancy and at time of cesarean section. Route is laparoscopic you can do, abdominal you can do, hysteroscopic you can do. Laparoscopic myomectomy is less operative time will be there, less blood loss will be there, less post-operative stay will be there, and it is done in serosal or submural type 2 or type 2 submucosal fibroid. Hysteroscopic myomectomy is done for type 0 and type 1 submucosal fibroid associated with more blood loss, and it is due to saline distension media. It can lead to electrolyte imbalance and perforation of uterus can occur. Contraindications, you will have broad, big ligamental fibroid. You have multiple tiny fibroids scattered through the uterine wall. You have infected fibroid and pelvic or endometrial TB. You have. Then endometriosis and adenomyosis. Endometriosis is functional presence of functioning endometrium, which is glands and stroma in sites other than uterine mucosa, is called endometriosis. Sites of endometriosis, you have ovaries, pelvic peritoneum, pouch of Douglas, uterosacral ligament, ectovaginal septum, sigmoid colon, appendix, pelvic lymph node, and fallopian tube. The rear sites, you have umbilicus, abdominis scar, episiotomy scar, lungs, pleura, ureter, kidney, arms and legs, and nasal mucosa. Risk factors, you have family history, obstetric anomalies of the genital tract, nulliparity may be seen, late marriage, late childbirth, in utero exposure to diethylstilbestrol, and hormone estrogen dependent condition also may be there. So, family history of endometriosis, obstructive anomaly of genital tract, nulliparity, late marriage, late childbirth, exposure to diethylstilbestrol, hormone dependent condition. It's the presence of functioning endometrium tissue in other sites is called endometriosis. There is also a few theories. Sampson's theory is reflex of menstrual endometrium through the fallopian tube. Implantation and growth on pelvic peritoneum and surrounding structures will lead to endometriosis. Coelomic metaplasia is metaplastic changes in embryonal cell rests of embryonic mesothelium capable of responding to hormone stimulation. Then you have metastatic theory, which is embolization of menstrual fragments occur through vascular or lymphatic channels and reaches the distant sites. Then you have histogenesis, which is endogenous biochemical factor can induce undifferentiated peritoneal cell to develop into endometrial tissue. Embryogenesis is endogenous biochemical factors can induce undifferentiated peritoneal cell to develop into endometrial tissue. Metastatic tissue is symbolization of menstrual fragments occur through vascular or lymphatic changes. Okay, it's from vascular or lymphatics. It goes to other places and it will implant. It explains brain, kidneys, and all. Okay, coelomic metaplasia is rest of the cells of the mesothelium capable of responding to hormonal metaplastic changes in embryonal cells. Okay, of rest of embryonic mesothelium. Metaplasia may occur. Osteogenesis is undifferentiated peritoneal cell induce undifferentiated peritoneal cell into endometrial tissue. So Samson, coelom, metastatic, and histiocytic. Histogenesis. All these four names you have to remember. Okay, clinical features, you will have dysmenorrhea, you will have infertility, dyspareunia, and dyspareunia is more prone or marked. Okay, premenstrual you will have and postmenstrual spotting may be seen. Urinary you will have frequency, dysuria, hematuria. Sigmoid colon and rectum you will have painful defecation, dyschezia, diarrhea, constipation, and melena. Hemoptysis may be there, and chocolate cyst or endometriosis of ovary or endometrioma can be seen. Ovaries will be distorted by numerous cystic spaces filled with dark brown fluid due to hemorrhage. Repeated hemorrhages will form large cysts which contain inspissated. What the heck? They contain chocolate colored material. That's more than enough. The dark color is due to hemorrhage. Chocolate cyst, endometriosis. Scar endometriosis seen in hysteroscopy scar, classic cesarean scar, myomectomy scar, ventral fixation scar, and fallopian tube operation. So you'll be having, first of all, dysmenorrhea, dyspareunia, infertility will be there. Premenstrual and postmenstrual spotting will be there. Urinary, you'll find frequency, dysuria, and hematuria. Sigmoid and rectum, you'll have painful defecation, diarrhea, constipation, and melena. Hemoptysis will be there if lung and malmet is there. Chocolate cyst, endometriosis of ovary or endometrioma. Okay. Complications. Okay, complications. You have a rupture of chocolate cyst, infection of chocolate cyst, and you have obstetric feature, which is intestinal obstruction. Urethral obstruction, which is sidonephrosis leading to renal infection, and malignancy you can have adenocarcinoma. Endocrinopathy, you will have corpus luteal insufficiency, you have leukolysis due to increased PGF2 alpha, luteal unruptured follicle may be seen, and ovulation may be seen, elevated prolactin level will be there, and double LH peak will be there. Investigation of choice is laparoscopy. Histopathological examination can be done. CA125 levels are raised in endometriosis. Monocyte chemotactic protein, which is MCP1, are raised in all peritoneal fluid. Then treatment, you have medical management, which is oral contraceptive pill which prevent progesterone withdrawal bleeding. You have danazol, GnRH analog, which is low pre-light, which is inhibition of hypothalamic pituitary axis. Surgical management, you have conservative and you have aggressive. Conservative is to preserve the pregnancy, and laser vaporization of vesicle lesion is also performed laparoscopically. Aggressive, if fertility is not desired, then diffuse adhesions is there. Total abdominal hysteroscopy and bilateral salpingo-oophorectomy can be done. That is aggressive. Then adenomyosis. You have presence of ectopic endometrial tissue and stroma located within the myometrium of uterine wall. Causes are age more than 40 years, multiparous, vigorous curettage, and excess of estrogen. Symptoms, you will have menorrhagia, dysmenorrhea, dyspareunia, and infertility. So abnormal function of subendometrial myometrium, retrograde menopause, myometrial contraction, interference in sperm transport and blastocyst implantation, and abnormal endometrial immune response. All of them can be leading to infertility. So wait 1 second. Give me a second. How do you say that? What is the name? Relaxation. Tamoxifen. Okay, inhibition of hypothalamic pituitary axis. Conservative to preserve the fertility. Laser visualization of feasible lesion also can be performed laparoscopically. Aggressive is fertility is not desired or diffuse solution. God damn it. How long have I been teaching? Do for another hour. I'll probably finish until space number 70. This is the important part, so maybe I'll do a few small topics, and I'll do page number 70 onwards. Benign diseases onwards till 26. No, till carcinoma I can do. Carcinoma tomorrow I can revise off very easily. And I think I'll do benign lesions of infertility and benign lesions. I'll try and finish it off. Okay, I'll finish adenomyosis. I'll finish drugs. Well, ovarian hyperstimulation syndrome also I'll finish. And infertility and sterility onwards I'll do a little bit later. These ones are not that important, I feel. So adenomyosis, of course, ectopic endometrial tissue and stroma inside the myometrium. Like endometrium, serosa, myometrium. Inside this part will be there. Age is more than 40 years. Multiparous women will be there. Vigorous curettage is may lead to this, and dilatation and curettage. If they do it vigorously, then it may just implant it inside, and excess of estrogen may lead to adenomyosis. So symptoms, they'll have menorrhagia, they'll have dysmenorrhea, they'll have dyspareunia, they'll have, and infertility, which is abnormal function of subendometrial myometrium, subendometrial myometrium. What is this? Okay. Dysfunction of the myometrium and all, endometrium and all will lead to infertility. Retrograde myometrial contractions. Myometrial contraction will be very much impaired. There is interference in sperm transplant and blastocyst implantation. That's what contraction and all will be impaired. So there will be blastocyst implantation also will be interference will be there. Then there is abnormal endometrial immune response. Immune response is also abnormal. Then PV examination, you will find symmetrical enlargement of uterus. Mobilization is not restricted. Associated with no associated adnexal pathology is there, and Halban sign, which is tender softened uterus on premenstrual. Bimanual examination is Halban sign. Tender softened uterus on premenstrual bimanual examination. Mobility is not restricted, and symmetrical enlargement of the uterus is seen, and not associated with adnexal pathology. No other adnexal pathology is there. Then diagnosis, you can do MRI. Junctional zone thickness is more than 12 millimeter. Gold standard is, however, histopathological examination. Histopath examination you have to do. Treatment of choice is surgery. Total hysterectomy, patients if they are elderly, localized excision or levonorgestrel containing IUCDs in younger women. LNG IUCD. Basically, like, because it's hormone dependent. If you decrease, if you provide estrogen hormone and all, it will act as a contraceptive and it will decrease. Okay. Hormonal therapy in gynecology. Honestly, if I finished here, maybe. Fine, let's do it fast. Estrogen in gynecology, you have replacement therapy, ovarian function, estrogen 21 days, followed by methoxyprogesterone acetate for 10 days. Then menopausal symptoms, reduce vasomotor symptoms, prevent osteoporosis, prevent cardiovascular diseases, all of this will occur. Pharmacologically, you have oral contraceptive, vaginitis, Turner syndrome, development of sexual characters you can provide, androgen insensitivity syndrome to prevent regression of breast development, osteoporosis, dysfunctional uterine bleeding, and delayed puberty also you can provide. Estrogen. So side effects, you'll have nausea, vomiting, breast tenderness, weight gain, endometrial carcinoma, thromboembolism, and cerebral thrombosis. It is contraindicated in thromboembolism, active liver syndrome, liver disease, severe hypertension, organic heart disease, and estrogen dependent tumor. Then you can provide we talk about clomiphene, which is selective estrogen receptor downregulator. Method of action: it binds to estrogen receptors in hypothalamus and prevents negative feedback of estrogen. Pulsatile secretion of GnRH is increased. Increased release of LH and FSH is noticed. Indicated in anovulatory infertility, induction of ovulation, assisted reproductive techniques, and male infertility with defective spermatogenesis due to hypogonadotropic hypergonadism. It produces superovulation. Assisted reproductive techniques which produces superovulation. So it binds to hypothalamus, prevent negative feedback, and pulsatile secretion of GnRH is increased, leading to increased LH and FSH. Indicated in anovulatory infertility, induction of ovary. These both are same. Okay. Side effects: you have headache, hot flushes, breast tenderness, abdominal discomfort, loss of hair, rashes, ovarian enlargement, and multiple pregnancy. Contraindications in hypogonadotropic, hyperestrogenic, cystic and cystic ovaries. Hypogonadism: there is a decreased development of gonads. If there is decreased estrogen also, you do not provide, and if there is cystic ovaries, you do not provide. Then aromatase inhibitor: it is converts testosterone to estrogen in post-menstrual menopausal women. It causes, however, it does lead to increased risk of breast cancer. You have letrozole and anastrozole, and it's used in postmenopausal ER by PR positive breast cancer. Testosterone causes breast cancer, therefore it converts it into estrogen. So it is given in postmenopausal receptor positive breast cancer and gynecomastia. Look, the way aromatase will convert estrogen to testosterone to estrogen, and this causes breast cancer. Okay, inhibitor, if you provide like letrozole and anastrozole, if you provide, it will inhibit aromatase, therefore there is decreased estrogen. Side effects will have bone fracture, nausea and vomiting, thrombosis may be there, vaginal bleeding will be there, endometrial cancer will be there, and hot flushes will be there. Then progesterone in gynecology: diagnostically, progesterone challenge test therapeutically for contraception, dysfunctional uterine bleeding, endometriosis, dysmenorrhea, luteal phase defect (LPD), endometrial hyperplasia and endometrial carcinoma, premenstrual syndrome, and postmenstrual menstruation. All of them are therapeutic uses of progesterone, like postponement of menstruation, premenstrual syndrome. Side effects: you will have nausea, leg cramps, mastalgia, weight gain may be there, which is due to salt and water retention, acne, scanty period, loss of libido, virilism, headaches, which is migraines, should be excluded. Depression and mood changes will be there due to low level of pyridoxine, as progesterone alter the tryptophan metabolism. Lipid profile: there is increase in LDL and decrease in HDL levels. Then we talk about mifepristone, which is Ru486. It is a competitive antagonist of progesterone and glucocorticoid receptors. Method of action is by blocking progesterone receptors, increase the release of prostaglandin from endometrium, menstruation, bleeding, or termination of early pregnancy can occur. Then uses: you have therapeutic abortion up to 7 weeks, you have emergency contraception, single 10 mg dose on 27 day of cycle irrespective of number of intercourse is enough. Mifepristone, one single dose. Induction of labor: it may be used for induction of labor. Okay. Therapeutic abortion, induction of labor. In uterine fibroids, it can be provided. Ectopic, because you need to decrease estrogen. Hormonal reasons, it can be provided. Ectopic pregnancy to cause abortion, and Cushing syndrome, if it is there. because it acts on glucocorticoid receptor also. Okay. Side effects, you have nausea, vomiting, headache, cramps, and failure or medical induction of labor. Maybe just failure. Okay. Headache, cramps. Okay. Contraindication, age more than 35 years, heavy smokers, adrenal insufficiency if there is there, and corticosteroid therapy if they're using corticosteroid and this is useless. Adrenal insufficiency is there, then it will increase more it will decrease the glucocorticoids even more. Heavy smoker and age more than this much. Okay. Tryptophan, okay. Then we have danazole, which is anti-gonadotropin. Method of action is by inhibitory effect on GnRH release, leading to decrease in LH, FSH, decrease in estrogen, progesterone, and testosterone. Its uses are endometriosis, dysfunctional uterine bleeding, fibroids, precocious puberty, postmenstrual PMS. Benign fibrocystic heart disease of breast. Side effects, you'll have diminished breast size, decreased libido, atopic vaginitis, hirsutism, and elevation of LDH, reduction of HDL. So GnRH related, you'll have hypothalamus will be there. GnRH analog agonist will analog is agonist is goserelin, leuprolide, buserelin. All of them can be provided. Buserelin. Okay. Leuprolide. Okay. Agonist. Antagonist, you have Girilex, Ciftralex, Gonadorelin. Okay. So basically they act on all of these analogs, antagonist and analog, agonist and antagonist. So agonist uses a intermittent pulsatile dose, increase the LH and FSH. They'll increase LH, FSH. Okay. Antagonist decreases the LH and FSH. Okay. So increase LH, FSH. Males, it will lead to spermatogenesis and increased testosterone. Males, they will lead to spermatogenesis and increased testosterone. Females, it will lead to ovulation, increased estrogen and increased progesterone. Ovulation, female lead to ovulation, increase in progesterone. Spermatogenesis, testosterone. Fine. So intermittent pulsation will lead to FSH and LH. Anovulation it may be provided in. Oligospermia it can be provided in, and delayed puberty also they can take. Continuous doses increases the risk, followed by decrease in LH and FSH. So continuous, if you give, first it will rise, then it will decrease. It can be given for breast carcinoma, fibroids, endometriosis, prostate cancer, and precocious puberty. Effects, you have hot flashes, vaginal atrophy, impotence in male, and osteoporosis. Then contraindications is pregnancy is a GnRH agonist contraindication. Antagonist also, GnRH whatever is there cannot be provided in pregnancy. Then uses in fibroid, prostate cancer, endometriosis, premature ovulation. Same as here. Side effects, hot flashes, vaginal atrophy, impotence in male, osteoporosis. Same as here. Ovarian hyperstimulation syndrome. OHSS, which is potentially life-threatening complication of ovarian stimulation by ovarian induction agents like clomiphene citrate, FSH, and GnRH. Okay, they are risk factors in young patient, PCOS patients, and in a previous history of OHSS, ovarian hyperstimulation syndrome. Basically, it is increase in vascular permeability, leading to a shift of fluid from intravascular to extravascular space. So there is increased plasma viscosity will be there. There is increased clotting will be there. There is depletion of sodium and albumin will be there, and third space fluid will be accumulated, manifested by ascites and hydrothorax. So clinical features, they'll have third space fluid accumulation leading to abdominal distension, ascites, abdominal discomfort and respiratory difficulty, and hydrothorax. And decrease in intravascular volume will lead to decreased urinary output, hypovolemia, and renal impairment. Hypercoagulable state will lead to venous thrombosis, and excessive ovarian response to stimulation will lead to size of ovary will decrease, but they are palpable on pervaginal examination. Classification, you have mild OHSS, which is enlarged ovaries 5 to 10 centimeter, and moderate OHSS, ovaries more than 10 centimeter, abdominal distension, nausea, vomiting, and diarrhea. Severe OHSS is ovaries more than 12 centimeter, ascites and hydrothorax can be seen. Management is conservatively admit the patient if hematocrit is more than 0.44 or abdominal or renal function is impaired. First line therapy, you have correction of hypovolemia, prophylactic heparin to reduce the risk of thromboembolic complications, and when abdomen is tense and ascites is there, then drainage of ascites should be done. Paracentesis, and surgical intervention has no role in OHSS. Okay, I'll take a break for some time, rest my voice and charge my phone.